What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about the types of stroke, including ischemic stroke and hemorrhagic stroke. We talked about seizure and anti-epileptics. We discussed neuroanatomy, neurophysiology, neuropharmacology, and now we're talking neuropathology, including diseases that cause muscle weakness. Some of these diseases affect the spinal cord, such as poliomyelitis, which is today's topic, and spinal muscular atrophy, which was the topic of the previous video. Other diseases that cause muscle weakness are the demyelinating diseases. Demyelination of the central nervous system is multiple sclerosis, but demyelination of the peripheral nervous system is Guillain-Barré syndrome. Other diseases that cause muscle weakness are diseases of neuromuscular junctions, such as myasthenia gravis and Lambert-Eaton myasthenic syndrome. Click the like button, click the subscribe button, and let's get started. I have two neuro playlists on my channel. One is called Neuroanatomy, which has anatomy, and one is called Neurology, which has neuroanatomy, neurophysiology, neuropharmacology, and neuropathology. Poliomyelitis is caused by polio, which is a virus. What is microbiology? It's the study of small life. Ology means the study of, bio means life, micro means small. Microbes are divided into bacteria, fungi, viruses, and parasites. Although, to be honest, some parasites are macroscopic, such as many helminths. The worms. Would you love me if I were a worm? Well, it depends. If we're talking about a symbiotic relationship, give and take, where both of us benefit, then of course I would love you. But if you are a hookworm depleting my iron, or a fish tapeworm sucking the living vitamin B12 out of my terminal ileum, then I might take an albendazole. That's why the study of microbiology is divided into bacteriology, fungology or mycology, virology, and parasitology. Today's topic is poliomyelitis. Polio is a virus. Is it a DNA virus or RNA virus? The answer is it's an RNA virus. Is it enveloped or non-enveloped? It is non-enveloped. Let's review some neuro. This is your brain. This is your spinal cord. Out of the brain comes cranial nerves. From the spinal cord emerge the spinal nerves. The brain and the spinal cord make the central nervous system. The cranial nerves and the spinal nerves are the components of the peripheral nervous system. What does polio cause? Well, we're going to talk about paralytic polio. If it's a paralytic polio, it destroys the anterior horn cells of the spinal cord mainly, and these are the beginnings of the peripheral nerves. For the pros, if a disease destroys your central nervous system, it can lead to upper motor neuron lesion. But if a paralytic disease affects your peripheral nervous system, such as polio, then this is most likely to cause lower motor neuron lesion. To learn about the differences between upper motor neuron lesion and lower motor neuron lesion, please refer to my neuroanatomy playlist. If you wish to see more videos like this in the future, please drop a brain emoji in the comments. Your nervous system is divided into central nervous system and peripheral nervous system. Central nervous system, brain and spinal cord. Peripheral nervous system, cranial nerves and spinal nerves. Paralytic polio spreads to the CNS. It mainly destroys the anterior horn cells, which are the beginnings of the peripheral nervous system. So for the most part, we expect lower motor neuron lesion. Definitions for the pros. Diseases or pathologies of the brain are called encephalopathies. Diseases of the spinal cord are called myelopathy. The word myelo means core. You can use the word myelo to describe the core of your vertebral column, i.e. the spinal cord, or you can use the word myelo to describe the core of your bone, i.e. your bone marrow. Does anyone remember multiple myeloma, or myelofibrosis, or myelophthisis? Hence the word poliomyelitis. Myelo is the spinal cord, itis is inflammation, and polio is the name of the virus. See, medicine makes so much sense once you understand what the French toast you're talking about. Let's dig deeper. Encephalopathy is divided into many diseases. If I affect the cerebrum only, not the cerebellum, not the brainstem, not the basal ganglia, just the cerebrum, we call this cerebritis, inflammation of the cerebrum. If I am a collection of pus, it's called an abscess. What if I am inflammation of the entire brain? And I'm talking cerebrum, basal ganglia, cerebellum, brainstem, I don't care, it could be anywhere. This is encephalitis. What if I'm inflammation of the coverings of the brain and the spinal cord? Meningitis. Remember that meningitis or the meninges cover the brain and the spinal cord as well. And that's why you get a stiff neck or nuchal rigidity with positive Kernick sign and positive Brudzinski sign. Next, let's talk about the spinal cord. If the disease affects the spinal cord itself, like polio, this is myelopathy. If it's inflammation, myelitis. If the disease affects the nerve root, it's called the radiculopathy. The radical is the root of the nerve. What if the disease affects the peripheral nerve? Peripheral neuropathy. Polio does this, Guillain-Barré does this and this, diabetes does this. Who else is going to teach you medicine like this? Your professor with his PowerPoint? Give me a break. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. Since polio affects the anterior horn cell of the spinal cord, let's talk about the spinal cord. Back to basics. This is your brain, which is part of the CNS. You need to draw your line in the sand, passing by the central sulcus. Anterior is mostly motor, posterior is mostly sensory. And you need to do the exact same thing in the spinal cord for embryological reasons, if nothing else. Anterior is mostly motor, posterior is mostly sensory. This is your spinal cord. This is the line in the sand. Anterior is motor, posterior is sensory. Motor is efferent, sensory is afferent. Then you have the spinal nerve, or the trunk of the spinal nerve, which is mixed. It has motor fibers and sensory fibers. What polio does is that it destroys the anterior horn cell on both sides, but usually asymmetrically, which means one is bigger than the other. One is more severe than the other. One can happen earlier than the other. And then what? What's going to happen if I injure the anterior horn cell? The anterior horn cell is in front of the line, so therefore motor. I will suffer motor deficits, meaning I'll be able to contract my muscles, which causes paralysis. And I can affect the muscles of the back, which can lead to scoliosis and lordosis. One of these skeletal muscles is the diaphragm, which can lead to respiratory paralysis. What's the name of the nerve that supplies the diaphragm? If you know the answer to this question, please comment below. This is a neuron. This is the soma. This is the axon. The soma is always unmyelinated. The axon could be myelinated or unmyelinated. The anterior horn cell has a collection of somas, and the somas are unmyelinated. And if they are unmyelinated, they appear gray. And this is why the anterior horn cell occupies gray matter, because it's a bunch of somas that are not myelinated by definition. In the spinal cord, the gray matter is more interior, but in the brain, the gray matter is more exterior. And then vice versa. The white matter is interior on the brain, but for the spinal cord, the white matter is more exterior. To understand the difference between upper motor neuron lesion and lower motor neuron lesion, let's go back to basics and talk about the cortico-spinal tract. For a more detailed discussion, please refer to my neuroanatomy playlist, especially my video titled Spinal Cord Tracts. Okay, let's say that I want to contract my left biceps muscle. So the impulse has to start from the right side of the brain, especially the primary motor cortex. Since this is motor, it has to start in front of the imaginary line known as the central sulcus. This part of the brain is the in front of the central gyrus. Then I descend and descend and descend some more in the internal capsule, especially the posterior limb of the internal capsule. Then in the midbrain, particularly in the crus cerebri or the cerebral peduncle. Then in the pons, mostly anterior part of the pons, the basis pontis. Then in the medulla, occupying the pyramids. Then I cross to the opposite side in the pyramidal decussation, or the motor decussation in the medulla. That's why we call this the pyramidal tract. And when I cross, I now go to the left half of the body. I started in the right side of the brain, but I'm going to cross to the left part of the body. Then I descend in the lateral cortico-spinal tract in the left half of the spinal cord in the white matter, because these are myelinated fibers descending like this. Then I'm going to end by synapsing here at the beloved anterior horn cell, and this is this neuron. And this is the end of the upper motor neuron and the beginning of the lower motor neuron. The lower motor neuron will start like this. Let me find my pink color. Oh, look at this. This is the lower motor neuron that you see here until it reaches the biceps muscle. We are supplying a skeletal muscle, so these are cholinergic fibers. If this is the biceps muscle, these are the fibers of the musculocutaneous nerve. Spitting a chemical known as acetylcholine onto a receptor on the biceps muscle known as nicotinic sub-M or simply acetylcholine receptor. Where does polio hit? Polio hits me here at the anterior horn cell. How about myasthenia gravis? It hits me here in the nicotinic sub-M or acetylcholine receptors. How about Lambert-Eaton myasthenic syndrome? It hits me here at the axon terminalis, the presynaptic voltage-gated calcium channels. To learn about myasthenia gravis and Lambert-Eaton myasthenic syndrome, please refer to my previous videos in this neurology playlist. Let's do it again. I'm trying to contract the left biceps muscle, so I start from the right side of the brain. This is the right primary motor cortex in the precentral gyrus. Then I'm gonna descend in the posterior limb of the internal capsule. And then I'm going to occupy the crus cerebri or the cerebral peduncle of the midbrain. Then I'm occupying the basis pontis of the pons, which is the anterior part of the pons or the base of the pons. Then the medulla in the pyramids. I'm going to cross in the pyramidal motor decussation in the medulla. And now I am part of the lateral cortico-spinal tract or the lateral funiculus of the white matter of the spinal cord. I started right, but after crossing, I became left. That's why we call this the cortico-spinal tract, because it starts cortico and then becometh spinal. All of this is the upper motor neuron until it ends by synapsing at the anterior horn cell. Synapsing with whom? With the lower motor neuron. This is the soma, this is the axon of the lower motor neuron until you end up by supplying the biceps muscle. This is what we call the musculocutaneous nerve, which is part of the brachial plexus, of course. And since this is the brachial plexus and this is the biceps, this is the fifth or sixth cervical spinal segment. If I have a disease that affects the upper motor neuron, I will have an upper motor neuron lesion. If I have a disease that affects the lower motor neuron, as polio does when it destroys the anterior horn cell, I will suffer lower motor neuron lesion. What are the differences between upper motor neuron lesions and lower motor neuron lesions? For upper motor neuron lesions, everything is hyper, so hyper, hyper up. But for lower, everything is low, hypo, hypo down. Upper motor neuron lesion, hypertonia, hyperreflexia, positive Babinski, so my toes will fan up. Lower motor neuron lesion, hypotonia, hyporeflexia, and my toes curl down, negative Babinski. Upper motor neuron lesion, spastic paresis, but lower motor neuron lesion, flaccid paralysis. Upper motor neuron lesion does not have atrophy, but lower motor neuron lesion can have muscle atrophy. And this is relatively common in paralytic polio. Upper motor neuron lesion, no fasciculations, but lower motor neuron lesions, fasciculations are common, such as in the tongue. There are many diseases in medicine that cause muscle weakness. The problem could be in the anterior horn cell of the spinal cord, which is part of the central nervous system. The problem could be in the nerve root. We call this radiculopathy. The problem could be in the peripheral nerve. We call this peripheral neuropathy. The problem could be in the neuromuscular junction between the nerve and the muscle, hence neuromuscular. We have muscular dystrophies, we have metabolic myopathies, and we have congenital myopathies. Example of anterior horn cell disorders. We have poliomyelitis, which is the topic of today's video, and spinal muscular atrophy, which was the topic of the previous video. Radiculopathy could be caused by Guillain-Barré syndrome, among others. Peripheral neuropathy is also caused by Guillain-Barré syndrome, is also caused by diabetes. Some vasculitides can also lead to neuropathies and more. Diseases of the neuromuscular junction include myasthenia gravis and Lambert-Eaton myasthenic syndrome. Muscle dystrophies include Duchenne muscular dystrophy and Becker's muscular dystrophy. Metabolic myopathies include diseases like McCordle disease, which is a glycogen storage disease. To learn more about glycogen storage diseases, please refer to my biochemistry playlist. Congenital myopathies is someone born with muscle problems. Mitochondrial inherited disorders fit in this category. This is the difference between a good doctor and a doofus with a stethoscope. A good doctor should evaluate a patient with muscle weakness systematically. Is it a problem in the CNS? Is it a problem in the nerve root or the peripheral nerve? Is it a problem in the neuromuscular junction, muscular dystrophy, metabolic, or what? Poliomyelitis. Itis means inflammation, myelo is the spinal cord, and polio is the name of the virus. What kind of virus? Is it DNA or RNA? It's an RNA virus. Which virus family? Because there are many RNA virus families. It's the Picornaviridae family. Poliomyelitis is fecal-oral transmission. Oh, so it's going to enter through the gut. Oh, and if it enters through the gut, we call it enterovirus. It's a virus related to the entero. Entero is the intestines, as in gastroenteritis. What happens? Well, I get polio from a fecal-oral route. For example, eating food or drinking water that has been contaminated with human feces species from an individual that has polio. So it can work like this. In areas with poor hygiene, someone may urinate or defecate in the soil near the river. Some people do it in the river or a lake. And then another person is going to drink for that water or wash vegetables with that water. And before you know it, there is poliovirus inside my gut, my GI tract, gastrointestinal tract. Polio is going to enter to the lymphoid tissue of the pharynx and the intestines. Does anyone remember the tonsils, the Peyer's patches, and more? From the gut, it reaches the blood. From the blood, it reaches the central nervous system until it destroys the anterior horn cell of the spinal cord. Usually in an asymmetrical fashion, one is more involved than the other. One can happen earlier than the other. Vaccines against polio. We have two main vaccines. There is the SALK vaccine and the SABIN vaccine. The SALK is killed, but the SABIN is live-attenuated. How do I remember this? Well, the SALK has a K and killed has a K. As for the SABIN, it has an I, which is a live-attenuated vaccine. The SALK is killed and it's given by injection. And that's another K, injection. What does killed vaccine mean? It means that we took the poliovirus, destroyed it, making it unable to infect you, but still able to trigger an immune response from you so that you can develop memory. But live attenuated, this is a virus that has been weakened but not killed. It will trigger an immune response from you to a greater extent compared to the killed vaccine. But there are problems with live attenuated vaccines. If you are immunocompromised, there is a non-zero probability that this live attenuated vaccine will activate and become like an active polio, causing you the disease rather than the protection. And that's why we try not to give live attenuated vaccines to immunocompromised people, including pregnant mothers. Because pregnancy is a status of immunodeficiency. Why? So that the mother's immune system does not attack the foreign baby inside of her. The baby is foreign to his mother, immunologically speaking. Inactivated polio vaccine is abbreviated IPV, and this is given by injection. Oral polio vaccine is abbreviated OPV, and this is given orally. Let's say that I want to travel to a country where polio is endemic. Which of these vaccines should I take? I should take the stronger one, the SABIN, because it's live attenuated, which gives you a more robust immunity compared to the killed vaccine. Also, the immunity from SABIN lasts longer than from SALK. And that's true for any live attenuated versus killed vaccine. Usually the live attenuated immunity lasts longer, requiring less booster shots in between. So, what are the advantages of the killed vaccine? It will not give you polio disease, that's for sure. But what are the drawbacks of the inactivated vaccine? Number one, it does not confer local immunity in your mucosal surfaces. It will not immunize unvaccinated contacts. What does that mean? Let's say that I did not receive any polio vaccines ever, and then I was exposed to someone with polio. How do I protect myself? The answer is SABIN, not SALK. The inactivated will not immunize non-vaccinated contacts. Another disadvantage of the inactivated polio vaccine is that it requires boosters. And finally, we will have to inject you, which is minimally invasive. Here is everything you need to know about poliomyelitis in one slide. It's a viral infection. It's an RNA virus from the Picornaviridae family. How did I get it? Fecal-oral transmission. It's an enterovirus. And in some cases, I can develop polio infection from a live attenuated oral polio vaccine, especially if I'm immunocompromised. This is rare, but it happens. in about 1 in 2.5 million. It happens, but it's extremely rare. Live-attenuated vaccines have a non-zero probability of actually infecting you. Signs and symptoms. We have 3 types of polio. There is abortive polio, non-paralytic polio, and paralytic polio. The abortive polio. Abortive because it goes away. These are just a bunch of flu-like symptoms like fever, like headache, like malaise, sore throat, maybe muscle aches, etc. Non-paralytic polio, it looks like meningitis and it smells like meningitis. When the meningitis is caused by bacteria, we call it septic meningitis. But when the meningitis is caused by a virus, we call it aseptic meningitis. With the famous symptoms, nuchal rigidity, headache, mental status changes, photophobia, phonophobia, positive Koenig sign, positive Brudzinski sign, and more. Last, the most severe, the paralytic polio. It's bulbar, it is lumbar. What is bulbar? Bulbar refers to your brainstem and the muscles supplied by the brainstem. Oh, cranial nerves leave the brainstem and supply my face. Yeah, your head and neck basically. So these are the bulbar symptoms, including inability to talk and articulate your thoughts, including inability to swallow. This is what we mean by bulbar symptoms. Lumbar, what does that mean? It means that it will destroy the anterior horn cells, mostly in the lumbar area of the spinal cord. Leading to what? Well, this is a lower motor neuron lesion, but it's asymmetric. So I'm going to have asymmetric flaccid paralysis, muscle weakness with hypotonia, hyporeflexia, negative Babinski, muscle atrophy, fasciculations such as of the tongue. Respiratory paralysis, because remember that if this happens to C3, 4, 5, it's going to affect the phrenic nerves, destroying the diaphragm, leading to respiratory paralysis. But here is a very, very, very important point. Paralytic polio does not cause sensory deficits, only motor deficits. For the pros, paralytic polio can lead to lordosis and scoliosis. Paralytic polio, even though it's not a meningitis, can give you a false positive Koenig's sign and Brudzinski sign, even if the meninges are not touched. How do I diagnose polio? Viral isolation by swab and by CSF. Swab, where do I swab? You can swab the stool because it's fecal-oral, or the throat because it's fecal-oral, or oral-fecal. And then take a sample from the CSF. Serology, to look for antibodies against the viral antigens. Get the CSF via lumbar puncture and do PCR, polymerase chain reaction, to diagnose this specific virus. When you tap the subarachnoid space via lumbar puncture, what will you find in the CSF? White blood cells are high because it's an infection. Proteins are high because it's an infection. Glucose is normal because it's a viral infection. Viruses are not considered to be living organisms. We call them particles, not organisms, because they are kind of living but also non-living at the same time. Basically, viruses do not want to eat your sugar because they are not living organisms. How about bacteria? Bacteria are living organisms and they will suck your sugar dry. Fungi, living organisms that will also eat your sugar. Tuberculosis, it's a living organism that will eat your glucose. You can do MRI to see the atrophy of the anterior horn cells. Treatment, physical therapy, respiratory support is extremely important, hydration, early mobilization and exercise, the fate or the disposition. If you have abortive polio or non-paralytic polio, I have good news for you. You'll get complete recovery in 99.999% of cases. But if you have paralytic polio, the recovery is variable. About 80% of patients will recover within 6 months. Other patients are not as lucky. This ugly disease can lead to permanent, irreversible paralysis. My Egyptian teacher who taught me English is an old man who has paralytic polio. To this day, he is still limping. He grew up in a poor village in Egypt where the vaccine was not available. Now let's have some fun. This picture is from Picmonic. See the link in the description. These are pictured mnemonics. So let's learn about polio. What is polio? Polio is a picornavirus. You see corns in the picture. Is it enveloped? No, it is non-enveloped. Non-enveloped. Is it a DNA virus or RNA virus? It's RNA virus, the rhino. Is polio helical, like a helix, or icosahedral? It is icosahedral, the cathedral. Is it positive sense or negative sense? It is positive sense RNA virus. Picornaviridae is a family of viruses that include the following viruses: rhinovirus, poliovirus, the polio player, Coxsackie virus, the cock in a sack, hepatitis A virus, the happy liver with an apple, A for apple, as well as echovirus. Picornaviridae family of viruses can cause aseptic meningitis. The apple scepter, meningitis. Aseptic meningitis. Picmonic has more than 1,400 mnemonics like these. Next, another important topic that doctors are clueless about. Post-polio syndrome. This is a syndrome, a bunch of symptoms, syn from synchrony, drome for disease, that happen after poliovirus infection, sometimes years or even decades after the paralytic polio infection. I develop some symptoms, some future sequelae. Why does it happen decades later? No one knows. It's an ugly, slowly progressive disease. Symptoms are very similar to paralytic polio, but this is what's unique. Pain. Remember, paralytic polio from the initial infection did not have sensory deficits. But post-polio syndrome has pain, which is a sensory symptom. Treatment, there is no cure up to this moment, so we just provide symptomatic support. Quiz time. Can you name the 2 countries in which poliomyelitis remain endemic up to this day? Let me know in the comments if you know the answer. Don't forget to take a look at my neuroanatomy playlist. If you want to learn about the types of stroke, ischemic and hemorrhagic, myocardial infarction, the types of cardiac arrhythmias, ARDS, acute limb ischemia, hypothermia, hyperthermia, drowning, toxidromes, and more, download my emergency medicine high yields course at medicosisperfectionalis.com. To learn about neurosurgery, cardiothoracic surgery, trauma surgery, orthopedic surgery, general surgery, preoperative care, postoperative care, and more, download my surgery high yields course at medicosisperfectionalis.com. To learn about opioids, anesthetics, stimulants, sedatives and hypnotics, anti-epileptics, antidepressants, antipsychotics, and anti-Parkinsonian medications, download my neuropharmacology course at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.